So hopefully you see the connection between this list here of social determinants of health factors that are found in a data-driven way in the lit review portion of the study from social work and healthcare. So, and one of the things I've actually done, just kind of sort of as an aside, I suppose, is in my when I'm teaching the 744 psychopathology class, I've actually added somewhat of a checklist like this for the students to kind of consider as in terms of what things what additional data they want to find out or ask the client or find out about, and what aspects of a list like this need to be captured as part of their treatment plan. Not necessarily that they can solve these per se, but the recognition in their treatment plan that these are contributor to whatever symptoms they're experiencing of whatever condition the clinician believes that they have. So I think that's a really, I was glad to see they had kind of listed this out as part of their, or maybe I created a list from the article, I don't remember which, but it's a good representative sample of data-driven social determinants of health. And somewhat along the same lines of the last comment I made on the previous slide was this concept of disruptive behavioral disorders like ADHD or autism spectrum disorder or oppositional defiant disorder, mood dysregulation, mood disorder, and that these are things when we're doing diagnostics. Really with any child, but particularly when we know we're working in a community where the type of social determinants of health factors that we saw on the last slide are more common, that these are things we should make sure that we're assessing for during and really before we render a diagnosis of those kind of particularly things like oppositional defiant disorder, conduct disorder, intermittent explosive disorder, uh, borderline personality disorder, antisocial personality disorder. These are things, and by the way, personality disorder should not be ascribed to children anyway, but I see it happen. But these are all things to consider when we're doing diagnostics, because I've seen it firsthand for years where children are ascribed these diagnoses. Doesn't mean they don't necessarily have them, but to render that diagnosis without consideration of the kind of social determinants of health that a lot of times are really obvious in some communities is doing that child a disservice in many ways. And by the way, if you're working with families in a community where, again, it's obvious that these, at least at the community level, if not with the individual family level, that these type of social determinant factors are prevalent, as we saw in the last slide, they're much more likely to drop out because they feel like you don't get it. So, and if we're only talking to someone about their depression symptoms or their children's behavior, and we're not considering we seem to be, you know, not connecting the dots with some of these social determinants factors when they are prevalent. That absolutely increases the likelihood that they're going to drop out, and particularly from communities where these social determinants are more prevalent. So few of them are getting to care anyway. That when we have half of those few that actually make it to care drop out, we're really creating uh, really significantly poor outcomes. So I really like this this slide and the following because it kind of describes in more detail what type of specific social determinants get in the way of people either getting children or families getting to care and staying in care. So we can just like with the video we saw at the beginning of the course, it's good to have a list of social determinant factors, but it's better to understand exactly what that how exactly that plays out. Lengthy waiting list for behavioral health care is a classic example of something that's, except for the very most wealthy, a significant issue. Many people work and uh, and have employer-sponsored insurance that can't get a provider in a timely manner for lots of different reasons. Uh, but clearly these things happen in a disproportionate way, either in terms of both how often there's a waiting list and how long that waiting list is, can be disproportionate to those in a community like the one that the authors are looking at in this study. So many of you have written in your post about the concept of co-located care being better than virtually connected integrated care, and that's absolutely true in communities that have experienced long histories of structural oppression and racism. They're much more likely to feel stigmatized, right, for lots of different reasons. And what the authors uh, are postulating is that looking at the data and the data they're generating from their own research, that co-location, in this case, being able to get your mental health care at the primary care location, um, may actually reduce stigma and then thusly increase um, access and retainment in treatment. And then also on the slide, from a macro policy perspective, in this case, SAMHSA, HRSA Center for Integrated Health Solutions, what do they think are some of the most important aspects in terms of addressing um, barriers to care for the most vulnerable communities? So they have this list here. Um, this is from the website, but from their website, but most directly from the authors as part of their lit review for the study. So if you flip to the next slide, you'll actually see a short clip on the Institute for Family Health um, community health centers. So I just pulled it's just like a 2-minute clip, but that's on the next slide. And also it's Institute for Family Health. So pretend you don't see that T there. I'm going to rub it out on my board here. Anyway, so here's a little bit of a couple data points um, on the community health center system that the authors are working with, and then you can see a short clip on that in the next slide.
As a primary care physician at the Institute, I strive really hard to make a difference in each patient encounter. I remember the details that you talked about last time, about the grandchild that was coming, or, the wedding that you were planning, or, the honeymoon you went on last time. These are the webs we weave and really, connect us to each other.
We try to make it so that you're seeing the same faces so that you can feel you're coming into a warm environment that's centered around you and your care.
You have to meet someone where they're at. Some of the common issues that people have to overcome is financial, insurance barriers, maybe not being able to afford medications. Housing issues are significant.
Whole person care is really about wellness. So how do you keep someone healthy, not just medically, but their whole being? So it's not just the physical, it encompasses the mental, it encompasses their ability to thrive in their environment.
I always try to do everything with every person to the best of my ability. We explain to them, this is what you need, this is how it can be done, this will benefit you.
I think we do so much more. I hear about patients' experiences at other places, and I think people get discriminated against for having Medicaid or not having money. We don't turn anyone away on their ability to pay, which is an amazing thing.
The patients are able to feel that it's a second home to them, that they are able to come in with no judgments. If they have any questions, they don't feel hesitant to come in and ask. Even if they feel that it's the simplest of questions or the hardest of questions, they feel that they have a connection with us. We're here to help you take control of your health.
So I thought this was interesting that I was able to find a short video on the which you can view on the when you flip over the next slide, that actually is the same symptom or screening tool that they used in the study. So I think you'll find that interesting, and you'll see here that they found depression most commonly in ADHD, uh, and I don't recall if they quantified what a list of disruptive behavior problems. You'd have to go and look at the raw article, but generally those are some ones that I mentioned in the audio comment before. But anyway, you can flip to the next slide, and there's a short clip on exactly what this pediatric symptom checklist 17 looks like.
The Pediatric Symptoms Checklist is a screening tool that can help primary care providers assess the likelihood for finding mental health issues. The purpose of this tool is to identify symptoms related to attention, internalization, such as anxiety or mood disorders, and externalization, such as behavioral disorders like ODD. After administering this tool, primary care physicians can score the questions to determine who is at risk and can benefit from interventions. This tool is not for diagnosis, but can help bring to the surface any difficulties the child is having with attention, externalization, or internalization symptoms. Here is an example of how to administer the tool to patients. Hi, Mr. Stevens, I'm Alyssa. I'm going to ask you to fill out a form today that takes a look into how your daughter's been doing.
Okay.
Okay? Can you please go through each item and rate sometimes, often, or never if they're true for your daughter? For example, the first one is fidgety and unable to sit still. Is this true for Cynthia? Sometimes, often, or never?
All the time, absolutely. So I would check often?
Yes. Okay, and please let me know if you have any questions.
Okay, thank you.
This is the completed PSC-17. I will now score the answers and identify whether or not there is further need for interventions or diagnostics. In tallying up each column, Cynthia scored a 4 in internalization, 8 in attention, and a 5 in externalization. As the cutoff number is 7 for attention, this indicates that Cynthia is at risk for an attentional disorder. There are also 2 other tools that may further identify the precise issues. We will go over these as well.
So one of the nice things about this study, because students ask me about this once in a while in terms of, well, what happens when the grant money runs out? Well, the honest answer is a lot of times some of this work just ends, and certainly, oftentimes, maybe most times, the researchers, try to kind of conclude their research as as a means of hey, there's good justification to add more grant tellers. But one of the things that was nice about this, both in the in the um, in the author's design, as well as the macro timing of this. You see that this published in 2016. Well, this is in 2017, as we know, that was the beginning of the Medicare integrated behavioral health billing codes, And so, while it's not stated explicitly in the article, I believe the timing of such was good that the social workers that were providing both some of the mental health care as well as the care coordination were able to continue their work and presumably have that billing support through Medicare and Medicaid.